I want to ask you something before we begin. Where did 120/80 come from? Think about it for a moment. That number is everywhere. It is on the posters in your doctor's waiting room. It is the benchmark your nurse references when she wraps the cuff around your arm. It is the number your family mentions when they ask how your blood pressure is doing. It has the status of settled scientific fact, universal, timeless, the gold standard against which every blood pressure reading is measured. But here is what almost nobody knows. The 120/80 target was not derived from studies of older adults. It was not established by analyzing what blood pressure produces the best outcomes in 70-year-olds, 75-year-olds, or 80-year-olds. It emerged primarily from research conducted in middle-aged populations, refined over decades of clinical tradition, and then applied to older adults as a universal standard, without the kind of rigorous age-specific evidence that should underpin a recommendation affecting tens of millions of people. And when researchers finally did study what happens when you aggressively push blood pressure in older adults toward that 120/80 target, what they found was not what anyone expected. For some seniors, pushing blood pressure that low does not protect the heart and brain. It threatens them. I want to tell you about a patient I will call Howard. Howard was 79 years old, sharp, independent, fiercely proud of managing his own health. He had been treated for hypertension for 12 years. When new guidelines emerged suggesting tighter blood pressure control, his doctor, conscientious and well-meaning, adjusted his medications to drive his readings closer to the 120/80 standard. Howard's systolic came down from 148 to 121. His doctor was pleased. Howard was told his blood pressure was now excellent. 6 weeks later, Howard came into my office. Not for his heart, for his brain. He was forgetting things. Not the ordinary forgetfulness of aging. Sharp, sudden gaps. He had gotten lost driving a route he had driven for 20 years. He had forgotten his grandson's name for a full minute during a phone call. He was frightened in a way I had rarely seen him frightened before. When we reviewed everything carefully, the timeline was clear. The cognitive changes had begun approximately 3 weeks after his medication was intensified. His blood pressure, measured at multiple times of day including during physical activity, was running consistently below 115 systolic on his new regimen. Howard's brain, which had spent decades with blood pressure regulated at a higher level, which had aging arteries that were stiffer and less responsive than they had been at 50, which depended on a slightly higher driving pressure to maintain adequate cerebral blood flow, was being underperfused, quietly, daily, producing exactly the kind of cumulative cognitive decline that looks like dementia but is actually iatrogenic, caused by treatment. When we carefully and gradually raised his blood pressure target back to a level appropriate for his age, vascular status, and overall physiology, his cognitive symptoms improved over the following 8 weeks. He drove his familiar route without difficulty. He remembered his grandson's name without hesitation. Howard had not been harmed by negligence. He had been harmed by the uncritical application of a number that was never designed for a 79-year-old body in the first place. My name is Dr. Lawrence Mensah. I am a geriatric cardiologist. I have spent 24 years studying the specific cardiovascular physiology of aging and the ways in which treatment guidelines developed for general adult populations can produce unintended harm when applied without modification to older patients. And today I am going to tell you the truth about blood pressure targets for seniors, what the research actually says, why 120/80 is not the right goal for many older adults, what the right target actually looks like depending on your specific age, your vascular health, and your other medical conditions, and why the most dangerous blood pressure for a senior is sometimes the one their doctor is proudest of achieving. Before we get to the specific numbers, I need to give you 3 pieces of physiological context that are absolutely essential to understanding why this conversation is necessary. Context 1. What aging does to the cardiovascular system. The cardiovascular system of a healthy 75-year-old is not a slower version of a healthy 45-year-old cardiovascular system. It is a fundamentally different physiological environment, and the differences matter enormously for blood pressure management. The most significant change is arterial stiffness. Elastic arteries, the large vessels including the aorta and its major branches, are designed to expand and contract with each heartbeat. This elasticity serves 2 functions. It absorbs the pressure wave generated by each cardiac contraction, buffering peak systolic pressure, and it maintains a forward pressure during the heart's resting phase between beats, sustaining diastolic pressure and ensuring continuous blood flow to organs between heartbeats. With age, the elastin fibers in arterial walls degrade, collagen cross-linking increases, calcium deposits accumulate. The arteries become progressively stiffer, less able to expand and contract. When a stiff aorta cannot absorb the pressure wave from a heartbeat, systolic pressure spikes higher with each contraction. And when it cannot sustain forward pressure during the resting phase, diastolic pressure falls. This is why isolated systolic hypertension, elevated systolic with normal or low diastolic, is the dominant form of hypertension in adults over 60. It is not the same disease as the combined systolic and diastolic hypertension seen in younger adults. It has different physiology, different implications, and different optimal management targets. The second critical change is autoregulation. The brain, kidneys, and heart are organs with highly developed autoregulatory capacity. They can maintain relatively constant blood flow across a range of perfusion pressures by dilating or constricting their local blood vessels. In younger adults, this autoregulatory range is wide. The brain maintains stable blood flow across systolic pressures from roughly 60 to 150. In older adults with long-standing hypertension, the autoregulatory curve shifts. The brain has adapted to function at higher pressures. The lower end of the autoregulatory range, below which blood flow begins to drop, shifts upward. A systolic pressure of 110 that would be perfectly comfortable for a 40-year-old brain may be genuinely insufficient for a 78-year-old brain that has spent a decade operating at 150. The third change is orthostatic vulnerability. Older adults have reduced baroreceptor sensitivity, the reflex that compensates for position changes by rapidly adjusting blood pressure. When a well-medicated older adult stands up from sitting or lying, the drop in blood pressure that normally lasts only a second or two can persist for 30 seconds or more in an older body with impaired baroreceptor response. If baseline blood pressure has been driven very low by medication, this orthostatic drop can produce momentary cerebral underperfusion, causing dizziness, falls, and in the most severe cases, syncope and serious injury. With these three physiological realities in mind, the question of what blood pressure target is truly optimal for a senior becomes considerably more complex than any single number can capture. Context 2. The J-curve, the most important graph in geriatric cardiology that patients never see in the 1970s. A Scottish physician named Stewart first described something in his hypertension data that troubled him. When he plotted cardiovascular event rates against achieved diastolic blood pressure in treated patients, the curve was not linear. It did not simply show fewer events as blood pressure went lower. Instead, it bent. It formed a J shape. Cardiovascular events were highest at high diastolic pressures, as expected. They fell as diastolic pressure was treated down to a certain range. But then as diastolic pressure fell below a specific threshold, events began to rise again. The lowest blood pressure was not the safest blood pressure. This finding, the J-curve phenomenon, has been debated, replicated, challenged, and refined over 5 decades of research. And while the debate about its precise mechanism and the exact pressure thresholds at which it applies continues, the core observation has proven remarkably durable, particularly in older adults, particularly for diastolic pressure, and particularly in patients with established coronary artery disease. Here is the mechanism that makes physiological sense of this observation. The coronary arteries, the vessels that supply blood to the heart muscle itself, fill during diastole, not during systole, during the heart's relaxation phase, not its contraction phase. The heart muscle is actually compressed by its own contraction, and blood is squeezed out of the coronary vessels during systole. They refill when the heart relaxes, and diastolic pressure pushes blood forward. When diastolic pressure falls too low, coronary perfusion pressure falls. The heart muscle, which requires continuous and adequate blood flow to function and survive, begins to receive less than it needs. In a young, healthy heart with fully patent coronary arteries, this reduction must be severe before ischemia occurs. But in an older heart with some degree of coronary artery disease, which describes the majority of adults over 70, the margin for diastolic pressure reduction is much narrower. Even modest reductions in diastolic pressure below a critical threshold can tip the balance from adequate to inadequate myocardial perfusion. A major analysis of the INVEST trial, which followed over 22,000 patients with coronary artery disease and hypertension, found that patients whose treated diastolic pressure fell below 70 millimeter of mercury had significantly higher rates of heart attack and cardiovascular death than patients maintained in a diastolic range of 70 to 90. The relationship was precisely J-shaped. Too high was dangerous. Too low was also dangerous. And the bottom of the J, the safest point, was not at the lowest achievable pressure, but at a specific moderate range. For older adults with coronary artery disease, and given that coronary artery disease is present in a very substantial proportion of adults over 65 even when not yet diagnosed, a diastolic pressure below 65 to 70 millimeters of mercury, achieved through medication, is a potential signal that treatment has gone further than the evidence supports. This is information that most patients on blood pressure medications have never received, and it is information that changes how they should be thinking about their numbers. Context 3. The SPRINT trial, and why its results are more complicated than headlines, suggested. The SPRINT trial, published in the New England Journal of Medicine in 2015, was a landmark study that seemed at first to settle the question of blood pressure targets decisively. It randomized over 9,000 adults with hypertension and elevated cardiovascular risk to either a standard treatment target of less than 140 systolic or an intensive treatment target of less than 120 systolic. The intensive treatment group showed significantly lower rates of cardiovascular events and lower all-cause mortality. The trial was stopped early because the benefit was so clear. Headlines immediately proclaimed that lower is better. Aggressive treatment saves lives. The 120 systolic target was validated. But reading SPRINT carefully, as I have done many times, reveals a more nuanced picture that the headlines consistently failed to communicate. First, SPRINT excluded patients over 75 who lived in nursing homes or assisted living facilities. It excluded patients with diabetes. It excluded patients with a history of stroke. It excluded patients with significant kidney disease. These exclusions removed precisely the patients in whom aggressive blood pressure lowering carries the highest risk of harm. The results of the intensive treatment group cannot be straightforwardly applied to patients who would have been excluded from the trial. Second, SPRINT used an unattended automated blood pressure measurement protocol that consistently produces readings approximately 5 to 10 millimeters lower than standard office measurements. A systolic target of less than 120 in SPRINT's measurement protocol corresponds to approximately 125 to 130 in a standard clinical setting. Many physicians applying SPRINT results in practice are targeting a lower pressure than the trial actually tested. Third, and most important, the intensive treatment group in SPRINT experienced significantly higher rates of acute kidney injury, serious electrolyte abnormalities, and syncope, fainting from blood pressure drops, than the standard treatment group. In real-world older patients who are frailer than SPRINT's carefully selected participants, these adverse effects would be expected to be more frequent and more serious. A subsequent analysis of SPRINT data specifically examining patients over 75 found that while the mortality benefit persisted in this subgroup, the rate of serious adverse events was substantially higher than in younger participants. The net benefit in the oldest and frailest patients was considerably smaller than in the overall trial population. The researchers themselves, in their original publication, explicitly cautioned that results should not be extrapolated to populations not represented in the trial. That caution has been widely ignored in clinical practice. So what is the right blood pressure target for seniors? The honest answer, and I want to give you the honest answer rather than a simplified one that fits on a poster, is that the right target is individualized. It depends on your age, your degree of arterial stiffness, your cognitive function, your history of falls, the presence or absence of coronary artery disease, your kidney function, and your personal values regarding treatment intensity versus quality of life. But within that individualized framework, the current evidence supports specific ranges that differ meaningfully from the universal 120/80 standard. For adults aged 60 to 70, without significant frailty, cognitive impairment, or fall history, a systolic target of 130 to 139 is well supported by evidence and represents a reasonable balance between cardiovascular protection and the risks of aggressive treatment. For some individuals in this age group who are physiologically robust, targets approaching 120 to 129 may be appropriate with careful monitoring. For adults aged 70 to 79, the evidence shifts. The 2017 American College of Cardiology and American Heart Association guidelines recommend a systolic target of less than 130 for this group, but this recommendation applies to non-frail patients who tolerate treatment without significant adverse effects. For patients showing signs of frailty, cognitive decline, orthostatic hypotension, or fall risk, a less aggressive target of 130 to 149 systolic is supported by the evidence and by the position statements of multiple geriatric medicine organizations. For adults aged 80 and older, the HYV trial, which was specifically conducted in patients over 80, found benefit from treating systolic blood pressure above 160, bringing it down to a target of 150 or below. That target, 140 to 150 systolic, represents the evidence-based goal for this age group in most international geriatric cardiology guidelines. Not 120, not 130, 140 to 150, substantially higher than the universal standard being applied in many clinics to patients of this age. The European Society of Cardiology guidelines specifically state that in patients over 80, a systolic target of 130 to 139 is reasonable if tolerated. But treatment should not be intensified if the patient is already stable at 140 to 149, and that targets below 130 are not recommended in this age group based on current evidence. These are not fringe positions. These are the stated recommendations of the most authoritative cardiovascular medicine organizations in the world, and they describe targets substantially higher than what many older patients are being pushed toward in routine clinical practice. The diastolic number that nobody talks about. I want to spend a moment specifically on diastolic pressure, because it receives far less attention than systolic in patient education, and yet carries the J-curve risk I described that is most immediately dangerous for seniors with coronary artery disease. In older adults with isolated systolic hypertension, the arterial stiffness that drives systolic pressure up also tends to lower diastolic pressure. The combination of high systolic and lower normal diastolic is called wide pulse pressure, and it is extremely common in patients over 70. When medications are used to reduce systolic pressure, they frequently reduce diastolic pressure simultaneously. If diastolic pressure is already at the lower edge of the safe range before treatment intensification, aggressive medication adjustment can push it into the J-curve danger zone. A diastolic pressure below 60 to 65 millimeters of mercury in an older adult with coronary artery disease is a clinical signal that should prompt a careful reassessment of the treatment regimen. Not necessarily a dose reduction without discussion, but a conversation with your doctor specifically about whether your diastolic is falling into a range where coronary perfusion may be compromised. Many patients on blood pressure medications have never been asked about their diastolic reading specifically. They know their top number. They know less about the bottom one. And yet for an older adult with stiff arteries and any degree of coronary artery disease, the bottom number falling too low may be the most immediate cardiac risk in their profile. The signs that your blood pressure may be too low. Because this conversation is about a risk that comes from treatment rather than from the underlying condition. I want to give you specific, practical signs that your blood pressure may have been pushed below your personal optimum. Dizziness or lightheadedness when standing up from sitting or lying is the most common symptom of orthostatic hypotension from overtreatment. It is frequently dismissed as normal aging. It is not always normal. It is sometimes a measurable, addressable side effect of excessive blood pressure lowering. Fatigue that is disproportionate to your activity level, and that developed or worsened after a medication adjustment is another signal worth discussing. Tissues including the brain and heart that are not receiving optimal perfusion generate fatigue as a symptom. Cognitive changes, including increased forgetfulness, difficulty concentrating, or mental fogginess that appeared or worsened after a medication change deserve serious attention and explicit discussion with your physician. These symptoms are too frequently attributed to aging when they may be attributable to cerebral underperfusion from overtreatment. Cold extremities, particularly cold feet and hands, that are new or worsening after medication intensification can reflect reduced peripheral perfusion from blood pressure that is lower than optimal for your circulation. In falls, any fall in an older adult on blood pressure medication deserves a review of whether blood pressure is dropping excessively during position changes or physical activity. Fall-related injuries, including hip fractures, are among the most serious complications in older adults, and orthostatic hypotension from overtreated blood pressure is a documented preventable contributor. What to actually do with this information? I want to be precise about the action I am recommending, because it is not what some viewers might assume. I am not recommending that you stop your blood pressure medication. I am not suggesting you aim for a higher blood pressure than your doctor recommends without discussion. Untreated or undertreated hypertension causes strokes, heart attacks, and kidney disease. The risks of high blood pressure are real and serious and well established. What I am recommending is a specific, informed conversation with your doctor that covers 4 questions. First, given my age and overall health profile, what is my individualized blood pressure target according to current age-specific guidelines, not the universal standard, my specific target? Second, is my diastolic pressure staying above 65 consistently? And if it is falling below that threshold, is that a concern given my coronary artery history? Third, have I shown any signs of orthostatic hypotension, cognitive change, or fall risk that might suggest my current treatment is more aggressive than optimal for my physiology? And fourth, are you familiar with the HYVET trial results and European Society of Cardiology recommendations for blood pressure targets in patients over 80? I would like to understand how those guidelines apply to my specific management. These 4 questions, asked specifically and in those terms, transform a routine follow-up appointment into a genuinely individualized cardiovascular review. They signal to your physician that you are an informed patient who understands the nuance in this area. And that signal, in my experience, reliably produces a more thorough and more honest conversation than the one that happens otherwise. Howard's story ended well. His cognition returned. His independence was preserved. His blood pressure settled at 138/72. Numbers that would have made a guideline checker somewhat nervous, but that represented the precise physiological optimum for his specific 79-year-old brain and heart. He told me at his last visit that he wished someone had explained this years earlier. That blood pressure management was not about chasing a number on a poster, that his body had its own requirements, that those requirements changed as he aged, and that the goal of treatment was not a measurement. It was him, his function, his clarity, his ability to live the life he had built. That is what optimal blood pressure management means for a senior. Not 120/80, not any single universal number, the number that keeps your specific heart perfused, your specific brain clear, your specific kidneys protected, and your specific body functioning at its best. Find out what that number is for you. It may be different from what you have been told, and knowing the difference could be the most important thing you do for your cardiovascular health this year. Tell me in the comments, has your doctor ever discussed an age-specific blood pressure target with you? Or has 120/80 simply always been the goal? I want to know how many of you have had this conversation, And how many have not? Share this with someone who is being treated for blood pressure and has never heard the word J-curve or the name HY-VIT. They deserve to know what the research actually says. Take care of yourselves, know your numbers, but more importantly, know what your numbers mean for you.